Okay, so we are set. So now we are going to Severance Hospital. Okay, Dr. Hong, can you hear me?
Of course.
Okay, welcome.
Okay, good morning, everybody. And first of all, I really deeply appreciate the proposal to join the TCTAP of our institute. So really deeply appreciate that. Before starting the procedure, let me introduce my team. Right side, Professor Kim, Byung-gu Kim, the professor, assistant professor Seo, he's from the Myeongja Hospital, and the imaging reading was done Jung-sun Kim. Okay, first of all, the Professor Kim introduced the patient cases.
Okay, hi everybody. So my name is Byung-gu Kim, so from Yonsei University. So today's case is 83-year-old woman case. So the 80-year-old woman presented with chest pain for several years. However, she did the spinal surgery, so pre-op evaluation heart CT was taken and showing the significant stenosis from the left main to LAD. On past medical history, there was no specific. Next slide. And on the demographic characteristics, her risk factor is hypertension, hyperlipidemia. So his current clinical presentation and diagnosis was a stable angina. Next slide. Yes, on the non-invasive study, echocardiograms, there was no specific, and treatment was not done because of she did not perform the exercise. On heart CT scan, the severe stenosis of proximal LAD was noted, and also with moderate stenosis of left main was noted. So next slide. This is the pre-op angiograms. So, on the RCA angiograms, there was no specific stenosis or narrowing. Next. Okay, as everybody knows, the diffuse luminal narrowing and circum was noted, especially the proximal LAD was tight stenosis was noted, including the left main. Next. On the spider views, maybe the LAD ostium was involved, and including the moderate stenosis of the left main, as shown in the CT scan, was also noted. Next. Okay, our target lesion is a proximal LAD, including the left main and main. Yes, this is our case presentation.
Okay, first the clinical lead for this patient, she wanted to solve her back pain problem. Actually, she already have the history of the surgery, but this is another second episode of the surgery. But unfortunately, we found that the very significant disease, particularly in the proximal LAD and the left main. Usually, in this kind of situation, one of the routine recommendation is a bypass surgery, and then they take the spinal surgery. It's 2 episodes of the major surgery is recommended. But when you think about the older age, 83, so personally I think most of the patient wanted to receive 2 major surgeries. So particularly in this patient and the patient family fix it, the left main and the proximal radius. But when we deploy the stent left main and the proximal radius, the patient should be waiting for the spine surgery at least 6 months or one year later. That is the main issue of this patient. So first of all, we have to be fix the left main and radial lesion, and the schedule the next spinal surgery as soon as possible. Therefore, as you look at the lesion, left main proximal radial lesion looks like similar. As you see in these live cases, sometimes somebody want to fix it just a simple crossover, or the two-stent technique, or the others. There is some issue. On angiographically, anyhow, one of the favorable findings is the right side coronary artery is quite a huge one, and the bigger one compared to the circle. And actually, on an angiographic finding, and the distal circle will be treated just medication. And the focus of the today is fix the left main and radius. Particularly, we want to fix it no contrast technique. Just the IVUS guided, fix it, proximal radius and a left main lesion. That is our plan.
Why minimal contrast?
Yes.
You are using a lot of contrast for OCT examination, but not in these cases.
Yes, definitely. So therefore, we will use the IVUS.
Okay.
May I ask you, you said that because it's only you do PCI only because she has 2 major surgeries, but on regular basis, if she would not, did you definitely send to surgeries patients, kind of like?
Is there any option or the opinion from you about that?
No. This is my question to you. What you do usually?
Usually, we recommend the surgery first.
Okay.
For the safety of if you deploy the stent and something happened during the non-cardiac surgery, they urgently call us, something wrong.
Okay.
So, first of all, protect us. We strongly recommend the surgery first.
It's a great case, at least. We will discuss, and we have a question.
Yeah, this is an important situation to face now every day. An elderly with preoperative surgery, and we can classify the surgery into major surgery. So you have to have no bleeding. This is any spinal surgery. So the best is to do a one-stent strategy with bi-freedom stent, which needs only 1 month, and the patient can with the stent for 1 month, and they can stop Plavix or ticagrelor, and then we can go for surgery. Otherwise, we will go PTCA alone is not recommended anymore. But only you have to put a stent. So either to put 1 stent, which is for leader trials by freedom, or to put a stent for 3 months, which is Zymes, or Onyx for 3 months, which I don't believe it's 3 months if it's acute situation. So the best is to go by freedom, and they have now 4 millimeter for new by freedom, and you can make a pot for the left main. I don't think the CX will need any stents, so you finish with 1 stent by freedom. This is my decision.
In my opinion, the guidelines said prophylactic stenting for non-cardiac surgery is only indicated for ACS patient or critical left main disease. So in my cases, I just go for medication and then back surgery first and then stenting.
In any left main?
This is a moderate left main, not critical. So I think the medical treatment.
But nobody knows. Nobody knows what's happening.
That's
true.
You see
That's
how
true.
how interesting discussion. Do you think that, and we see your intended strategy would be use IVUS and FFR, and maybe you can explain why you should think about, and we have here great experts, and why you think about IVUS and why you think about FFR for this patient?
I partly agree with Dr. Lee's opinion. However, situation is quite different. It means when the patient for first surgery is for the non-cardiac surgeon. So every non-cardiac surgeon don't want operation without cardiac disease improvement or fix. So he never operate again. So the patient always come back. Yes, so my surgeon needed cardiac treatment first. Yeah, so we firstly anyway fixed this disease first. Usual our practice.
Usual, and there is a real situation, not guideline oriented. Every guideline is strictly, but what is the reality in the practice? Every non-cardiac surgeon wants to be related with some cardiac event. So you have to fix in every cardiac problem before the non-cardiac surgery. There is their side.
So let's see. Okay, go ahead.
Okay. Show me the first slide. Okay.
Next.
엔조.
네.
프로로 찍은 거 좀 보여주세요. 요거 찍은 거. 엔지오, 신의 엔지오 한 거 시작한 거 보여주세요. Yeah, actually, this patient is the elderly patient. There is some possibility of peripheral artery disease. Next, you see there is some device in the patient back, and advance that is the diagnostic, right side diagnostic caster, and next. And exchange a steel wire, and then using this is the XV for the left side.
What's the size? 6 or
7 French.
7 French, right.
Side all. Next. And then introduce a wire without any the contrast dye guidance. Next.
You are using calcium line for wiring.
That is one of the indicator. And then change the direction and advance the wire.
So
and
far, no contrast.
Yes, of course. Next, that is the LAD. And then we will do the IBIS examination for the lesion location and the other information. Professor Kim will provide the IBIS information. Next.
Fluoro next. Yeah.
Okay. That landmark for the that is one of the important landmark for the stent deployment. That look at the transducer of the IBIS. One of the important landmark for the stent deployment. Next. And then I will do the guide wiring in the circ or OM branch and test it.
No contrast.
Still no contrast.
Yeah.
Okay.
No contrast technique.
Yes, and do the next IBIS examination. Okay. Your turn, Professor Kim.
Oh yeah, I'm Jung-Sung Kim. I will explain the IBIS finding. So we pull back the IBIS to the distal LAD as shown in this image, distal reference around 3.5, and there is a calcified plaque was shown between 3 to 6. There is a lots of calcification in this patient.
3.5 alone.
And this is a pullback. This is a LAD region. Was a minimal lumen area 1.7 and approaching to the LAD ostium as shown in this image. And the plaque was distributed. The opposite part of the most of plaque opposite part to the ostium of the circumflex. This is a left main. So left main ostium minimal lumen area 1.96 and left main minimal lumen area 3.4 and lesion length around 35 millimeter. Is there a question for the IBIS finding?
Yeah, it looks like the vessel diameter is for left main is close to 5, and
Yeah,
for proximal
left
LAD
main
is
around
4.0,
5, yeah.
which is
Yeah.
very important findings, and that means that actually if you do a good, and you will do for sure a good intervention, that restenosis or stent thrombosis rate would be very low.
So there is lots of discrepancy distal part and proximal part, because distal is a mid LAD and proximal is a left main ostium. So we will cover between mid LAD and left main ostium. So in this patient, I think it is very important to guided IVUS because we have to oppose the stent stroke well, which can improve the stent drilling process.
Could you explain us a bit about plaque morphology, because it's not very homogeneous?
Yeah, plaque morphology is mostly mixed plaque. Yeah, lots of calcification, and there is some attenuated plaque around the left main area. So this is not a homogeneous plaque in this patient.
Kim, I have a question. So the question is how to evaluate the intermediate lesion on the left main. And you know that there is a strong concordance in the left main between IVUS and FFR. But you choose since the beginning IVUS. The catheter was a side-hole, that is not the best one for assessing FFR. So why did you choose IVUS? Because you are more trusting on IVUS when you have to judge an intermediate lesion, or why?
Actually, we can evaluate intermediate lesion either IFFR or IVUS. So there is some data, criteria of cutoff value of the cutoff value of minimal lumen area to predict the FFR. Especially, it's quite different between Western people and some Korean and Eastern Asian people, because I think that there is some difference of body weight and other ethnic difference. So in Korean data, we have a criteria 4.8 square millimeter for predicting the functional ischemia. However, in Western data shows around 6.0 square millimeter. So in this patient, 3.4 square millimeter is quite significant ischemia to predict the functional problem in the future. So I think this patient to have a definite indication for the left main stenting.
May we add something more that in any case you have 2 lesions on the LAD, so they are making the assessment of the left main difficult. The circ is a tortuous with a summer lesion there, not very important. So it's not easy to make a single evaluation by FFR. So it seems to be very reasonable to go by IVUS and making this assessment.
Yeah, it's good, good point.
10, 12, deeply.
Okay. Show them the endoscopic finding.
아까 좀 네거티브 아까 거? 아, 오케이.
You already put the stent.
Yes.
You're quick. Could you explain?
Of course.
Could you explain a bit what you choose and why?
Right. Okay, back. Okay, first of all, based on the IVUS finding, ostium of the circ is that the lumen area is more than 5.0. It means that just stent crossover, the strategy is more adequate this patient. There is some risk of the compromise of the circ after the stent crossover. That is the reason why I already insert the wire in the circ. And then one of the panelists recommend we will now deploy the stent, selected the biofreedom. We have some experience of the use of the biofreedom before the surgery. Not some patient who refused the bypass surgery for the non-cardiac surgery. So actually, how many patients?
19.
Look at that.
Yeah. 19 patients was performed biofreedom
You have a
implantation
slide?
before non-cardiac surgery, and meantime is 4 weeks later, all patients underwent non-cardiac surgery without complication, means no stent thrombosis or no further bleeding. So and now there was no MACE, including the hard endpoint. Everybody is it's okay. Yeah. So.
Therefore, we have some agreement, consensus of the use of the biofreedom in our intervention group, particularly this patient, and as well as this patient is an elderly patient. So the risk of the bleeding. So in this kind of situation, we prefer the biofreedom. That is the real power of the non-polymer coating triglyceride stent. And then we will do the balloon dilation and the medial AD, proximal AD, by the guided the IBIS guide, the transducer and the predilation.
What is the size of balloon?
That is a non-compliance
Non-compliant balloon. This is important. Yeah.
3.5. And then? Next. Okay. Actually, this is a 3.0. I know that it's a small size for the left main. We will dilate the left main with more. The reason why actually more the correct selection of the biofreedom, actually this should be a 3.5. However, the nominal pressure for deployment of the biofreedom only 6 is too smaller. So that is the reason I select the 3.0 and post-dilate with an additional balloon.
Professor Hong, I'm keen to know how did you implant the stent to make sure that it covers the ostium of the left main without any contrast injection?
Yes, let's check it. We don't know. So we do the IBIS again.
Yeah, so far, nobody knows.
Yes.
Can I add to this? There is a software with Philips machine nowadays about you just doing single injection, and this calibration and delineation of the walls of the arteries, I mean the CX LED, and then this is being the screen roadmap, and then you put the wire through this one without any contrast.
Right.
Do you have an idea about this?
No.
This is the most updated machine, and I think this should be the future aspects that to add it to every machine, not to use contrast with just the computer and adding the lines. So this is what they're using nowadays.
We are still using just the conventional IBIS and the angio machine and software using that one. I usually do this
Maybe
kind
we
of
can ask
procedure.
for other panel members what they are thinking about this and what they would do, or
This is a 3.5 non-compliance balloon for dilation of the proximal part.
3.5 for distal.
Proximal. Okay, if you wanted that.
No, I ask to you.
Why not
because
4? Why not 4?
It really depends, or we do IBIS guided, or we do like what we want to do. Julia, maybe you can comment on that.
Stop just before rupture. So.
Go ahead.
While they are
16
working,
now?
I wanted to go back to the story of the ostium to be
16?
very precise in, because in fact there are data showing that in 1/4 of the patient, when we wanted to reach the ostium, we are missing the ostium. And so I think that it's not so crucial if there is not a huge pathology
But
around.
the question, is it essential to cover the ostium in every left main mid part, I mean the distal left main? I mean, if a distal and body you're not reaching the ostium, is it mandatory to cover the ostium? Because
it does not seem based upon the data.
I can say I have 20 years experience with left main, and then I said, and I also in this very hard discussion, I say the same what you said, no.
Yeah.
And then I had couple each other two really osteal, restenosis and then Hurgia. But it's, of course, it's really very rare, and I'm agree this is practically impossible to cover by.
Okay, let's evaluate the stenting procedure with the IVUS. If there is something wrong or an unsatisfactory finding, we will do the next step. And another one is, even though I cross over the stent deployment, cross over the circ, hemodynamically, there is no change. Blood pressure is stable. There is no ECG change. Okay, go ahead, Professor Kim.
Pull back from the distal lady. So, yeah, not yet stent. There is, yeah,
nice
stent.
transition.
Yeah. Yeah, stent expand well, and no dissection. Quite evenly well expanded stent. The stent is around 3.5. Yeah, there is a. This is the pullback to the. Let me check.
Okay.
Again. The ostia.
We will do the IVUS once again
Yeah.
for evaluation of the us.
Maybe we can
Ostia,
discuss
ostia.
about stent
Yeah.
expansion. Who wants to say something about that?
Okay, once again, IVUS again.
I think distally we see that we have nice stent expansion, no distal edge dissection, which is important. If we go further proximally, then we saw already on IVUS that the ostium of the circumflex is wide open, which is very reassuring. And now the discussion is whether or not
Yeah, stent
left
is well
main
expanded.
would benefit from additional post-dilatation. We see there is a lot of
distal
remodeling, a
edge of
lot of
stents.
plaque burden. And for me, it would be also important to see the proximal reference segment in the left main to
Symmetrically
make
well
that
expanded
decision.
stent
Yep.
is around diameter 3.5.
For me, the same.
Because in the end, we don't want to treat the plaque. We want to make
Yes,
sure that
there
we
is a-
have smooth lumen transition from proximal to
Circumflex
distal. So
ostium is
proximal
well
lumen
opened around
is important.
5 o'clock. Is already passed, and there is no dissection.
Based on the
And
IVUS
well
finding, we have to
expanded, yeah.
deploy the additional stent for the asthma of the left main.
Do you really think that you need one more stent?
Is there? Well, I'd like to ask about it.
Both.
It's okay.
Both for sure.
I mean,
I
is
think
it
with
wise
mild diseases,
to put another stent after putting stent left main, or you make it with the IVUS from the beginning and then take a long stent from the ostium to the SLED? So what are the difference? Because overlapping with stents, left main is not good for the patients. What do you think?
I think so. Personally, as you know, I strongly believe the image, and based on the IVUS finding, the proximal to the left main, actually the lumen size is quite bigger.
Yeah, but this is our question actually. Do you think that maybe you can use a bit bigger non-compliant balloon for pot technique and to optimize the stent, especially in left main?
Tell me about the smallest lumen cross-sectional area left main.
Yeah.
It depends on the lumen area. So what I mean is that if the lumen area is, as we know, less than the 9, I will do the more inflation. But the more than a 9, we don't need that actually. You know that when we do a procedure, particularly in the elderly patient, personally I think that perfectness is not good. If we achieve 100% satisfaction, it makes us some complication. I don't like it. Even though the result is 90, she's happy. So it depends on the left main size. First of all, the left main size more than a 9, she can achieve do the non-cardiac surgery 1 month later.
What about
Clinically, I like that.
distal part of the stent, little bit under, it looks like a little bit underdilated.
Okay. Professor Kim,
yeah, just
what is
add-
your opinion?
Distal
no,
part.
just the distal edge of stent is not.
Tell me what
yeah.
is the area
Yeah.
of the distal margin of the stent and the
Yeah.
most smallest lumen area at the left main.
Let me check again. The distal part.
Okay.
Yeah.
Distal edge, okay.
This is the distal part of the LAD. The minimal the stent area is around. Let me check. Yeah, 6.9.
What?
6.9.
6.9.
Yeah, it's
almost
okay,
to be
yeah.
7.
Yeah, almost 7. Yeah.
Okay. The
And
next,
also
smallest lumen area at the left main.
left
Left
main.
main.
Left main. So we already measured around proximal LAD was 8.25 and left main, distal left main around 8.3.
8.3.
Yeah.
We will, okay, as you want, I will do the additional balloon at the proximal LAD. No, left main.
Left main, yeah. For non-compliant, looks like. Yeah.
Sure. 저기 4.0,
NC?
4.5 NC.
40 NC balloon? 짧은 거? 10이나 8? 네.
아래요 코달.
So while you are working, I have a question. We saw during the entire morning a systematic use of IVUS, but only marginally we saw measurements automatically display. And that is very important. So we think that both based upon the longitudinal view and the cross-section, we must place our decision based upon measurements. So instead to ask every time to have the MLA, how big it is, we wanted to have probably an advanced software that can help us to get immediately this measure. There are already significant advantages with the recent software, but it is something that is more practical compared to make a speculation on moving imaging and single cross-sectional view.
If the guiding catheter has no side holes, is it the time now for IFR or FFR for this distal left mid to see this to need spot or not, or to change it to another stent, or just to you have to complete the procedure with the IVUS guided?
Actually, I use prefer the guider with a sidewall. When we do the pressure wire measurement, at that time, a little pullback of the guider outside of the ostium and administer the IV, not the intracoronary. So it does not any problem using the use of the guider with the sidewall. Okay, go ahead.
Okay. Nominal?
The other issue is, of course, we don't have good reference values for FFR after stenting. So I guess in this case, FFR would be good if there is any doubt about the ostium of the circumflex. But for optimization of the LAD, I believe IVUS imaging is way better.
Okay, guys. No.
That's a different. Okay. Let us check the ostium of the left main with IVUS again.
This will be interesting now because you perform post-dilatation proximally. That is at the bifurcation with the circumflex. And what we typically see is by these post-dilatations, we change the geometry of the carina. And it will be interesting to see how the ostium of the circumflex is looking like right now. Probably it will be more elliptical shaped.
If there is any change of the hemodynamic because so far we do not use the contrast dye. We don't know about the compromise of the.
You are really brave, I said.
So at the time,
I would be too nervous to do like this. But of course.
Okay, go ahead.
It's no reason to be nervous.
Yeah, pull back from
We have done the IVUS, you know where the plug is, you know what will happen. To me, this is the beauty of imaging. You don't need to be nervous.
Actually, this is like one of my friends said, PCI is contrast and angio-based procedure, not IVUS-based.
It's more expanded, compared before.
What about the opinion about
this is IVUS plastic.
So let me check
this is
again the area.
Okay. If there is some hemodynamic change, actually we prepared the pressure wire for the obtuse marginal. But practical point of view, nothing happened. So we don't need a pressure wire to save the resources.
Area.
Oh, okay. Professor Kim, show them that the
area.
Yeah.
I right now measuring the area.
Actually, we did a 4.0 non-compliance balloon for the left main.
So, austere area of LAD and left circumflex bifurcation area increased from the 8.3 to 8.9. Also, proximal left main. I will check again. There's some mistake. Yeah, this one.
Yeah.
So previously we measured the 8.2. But this part is a very calcified area. Calcified have lots of calcified plaques, so I think it's not so much enlarged after, even though with post dilation. So it's quite similar, 8.3, but it is acceptable. Yeah, for the minimal stent area, because as you know, the previous report is predict future clinical outcome, future event. Is LAD ostium 6 and polygonal of confluent area 7 and distal left main usually.
I have a question to you. How
8? Yeah.
How the patient can tolerate the procedures with a spinal disease for a longer time? So it should be as rapid as possible for the left main LAD and no need for optimization a longer time, because this patient cannot lie flat, or what do you think?
Whatever the stent was deployed, based on our experience using the biofreedom, I think it's even though we deploy the left main, still we have steadily increased the confidence about the biofreedom. So 1 month later, personally, I think as a non-cardiac surgery, spine surgery will be safe.
And Professor Hong, how long would you allow the surgeon to withhold the antiplatelet agent?
That time, we usually recommend the current guideline. What I mean is that stop the Provix is 5 or 7 days, and then continue the aspirin. So even though we recommend the aspirin, surgeons want the discontinuation aspirin as well. That is a surgeon's mind.
I guess for spinal surgery, they would not want any antiplatelet drug on board.
Brain and spinal corner surgery is very dangerous.
We continuously say that, okay, even though using the aspirin and take a non-cardiac surgery, it will be safe. Continuously say, but anyhow, they don't like to use aspirin.
So in the LEADERS trial, they used dual antiplatelet therapy for 1 month, but the rates of stent thrombosis was 2.2%, which is not low. Aren't you afraid to use such a short-term of dual antiplatelet therapy for left main stenting?
I have some different opinion about the LEADERS trial. What I mean is, the random clinical trial, patient age is think about that. The study population which were included in the LEADERS 3, really high risk patient. Therefore, stent thrombosis rate is 2%, quite reasonable at that situation. And what is the control part? Bare metal stent part, there is a stent thrombosis rate also 2%. It's similar. It means that the patient study population for that study is really high risk.
Well, I agree, but don't you think that probably a strategy with the second generation drug-eluting stent and 3 or 6 month dual antiplatelet therapy would have been safer?
Right. That one of is a real common situation. Somebody have the diagnosis with a cancer. He want a surgery as soon as possible for the prevention of the dissemination of the. He really have a fear about the cancer. I want a cancer surgery fast. We have to fix it. So that is that case. Okay, you have to wait 6 months later. You will be happy, but patient and patient family does not wait for the 6 months.
Previously, I explained the severance experience as 19 patients. It's nearly all patient diagnosis was a cancer. So our experience only performed at the non-elective cardiac surgeon patient.
Maybe you will explain now what you are doing now. You will go to measure FFR for
Yes.
Excellent.
There is some time remain for the service for you. We will measure the pressure wire for the surgery.
You have a lot of time.
Without the contrast.
It's not at least my recommendation. I only ask why you would want to do that.
You don't need it. I will finish that.
Okay.
Is it mandatory to open the struts of the left main CX?
No, I don't think so. It depends on the physiology assessment. If there is the value of the FFR is less than 0.8, we will dilate.
This is very important because in the past it's a routine, but nowadays we are not using this one. Even because the FFR is normal, we are not going to open it because they're claiming that if you open these struts, this for further examination of the circumflex, if you can go inside without endothelial proliferation.
pressure 해주세요. 네. 저기 헤파린 3,000만 잠깐만. 헤파린 3,000만.
헤파린 3,000. 와이어 리무.
아니야 이거 아직 안 빼. 프레셔 와야 됐어요?
예.
나 그냥 들어가면 돼?
이쪽으로 들어가실 거잖아요.
이퀄리제이션 LAD에다 대고 할 거예요.
아, 예.
So, Doctor, will you finish without final angiogram?
Of course. I already declared that. We will not use the contrast for this patient. You never expect that.
But we will ask you at least 2 projections.
And be sure to have recorded at least the IVUS.
In case of a spinal disease, needs surgery, is it good to go through the radial rather than femoral approach because the patient cannot withstand to stay for a long time after the procedures?
I'm not sure about it though. Which access is better? Frankly speaking, the selection of the femoral access for this patient is for the non-contrast. Okay, this is a pressure wire for the equalization.
Flush now. Flush. Distal flush. Distal flush.
After the equalization of the pressure wire, I will introduce the pressure wire in the obtuse marginal.
Okay. What amount of adenosine you use now?
Pardon?
What amount adenosine you use now?
Sorry, I don't understand. Sorry.
Adenosine, what is the dosage of adenosine?
Adenosine.
Adenosine dose.
Adenosine dose will be the IVIS. Huh?
140 micro
Usually 140 or
Yeah, but
200.
this
per minute
yeah,
occasion. Yes.
200, this is right.
But the equalization is done with the 3 wires?
Okay. Okay. Now equalization was done in the LAD. I will remove the pressure wire.
Do you use IFR or you still prefer FFR?
Sorry that the
FFR.
we sometimes use a pressure wire alone. 가만 있어. Introduce. 가만 있어.
What microcatheter are you using to exchange the wire?
Okay, this is a Corsair
Okay.
for the delivery of the pressure wire.
Looks like the patient is very calm and hemodynamics is good, and because you are also so calm.
Yeah, the spinal.
Yeah. That means the procedure is going very well.
For the sake of discussion, regarding the IFFR and FFR, do you think that in the future that we're going to start with IFFR if it is no ischemia, then go to finish the job, or we have to stick to the FFR because there is a contradictory regarding the two trials. What do you think?
For me,
Yeah.
I'm not the physiology expert. Please ask about it. The other panelists, the expert about it.
Okay.
Sorry that. A little bit wider outside of the ostium. Okay.
So do you want to comment about the curves?
I was the adenosine infusion start.
Yeah.
바꿔. 일단 가봐.
So you have an overshooting. The equalizer
제로 라인을 다시 할 수 있어.
very high.
가 일단 가. 인퓨전 해.
Right now your distal pressure is higher than the proximal.
Yeah, probably you need another calibration at guiding tip and then start.
오케이.
지금 캘리브레이션 하면 되잖아. 여기서
다시 캘리브레이션 해봐.
이퀄라이징.
오케이. We will do that. 다시 해봐. 제로 라인을.
Pressure wire pull back at guiding tip.
뭐 얘기를 해. 조금만
There
더
was a
나왔다.
very good comment, I guess, from Julia, that of
Right.
course it's not always very easy if you have some tortuous arteries and quite complex PCI to
해봐.
measure the FFR, and then maybe it's even sometimes it's a bit harmful.
오케이.
됐어?
네, 어드밴스. 이 정도만 하셔도 돼. 네, 오케이.
갑시다. 더블로.
Do you start it now with adenosine?
Yes,
okay.
IV adenosine. It
Okay.
takes some time
Yeah,
to
yeah, sure.
dilate.
Yep. We just check.
Did you administer some nitrates before?
Yes.
No.
It's a bit conflicting answer.
That's okay.
Okay. Pressure down.
It's real life.
Yeah.
Okay, now we see that something happened.
So not significant.
Actually, this is a double dose of the usual IV adenosine.
Yeah.
I think now pull back.
Do you need the pullback?
Yeah, pull back and check equalization at guiding tip.
Okay.
But you need to stop the adenosine first.
Yeah. So not equalized pressure.
Yeah, but the stop adenosine magic is okay. Yeah, I guess it was quite. Looks like
Okay.
negative.
If you have time, once again, equalization again.
Equalization
Stop
and
adenosine.
guiding tip.
So the final message is it's much easier to run one IVUS pullback than doing an FFR
Completely
assessment.
agree with you, Julia. Completely.
Good comment.
No, it's not always this way. Yeah, come on.
Yeah, but you know, I think you have a point. Doing a correct FFR measurement or any hemodynamic measurement for this sake is sometimes more demanding
That's
than just implanting a stent. So
That's right.
I think this is an important point for training and also the way how we need to teach our fellows.
We did
Pay
the
attention
equalization
to the detail
again.
and so on. And be patient.
Okay. Baseline.
Okay, start.
Adenosine. Start again.
아까 헤파린 드렸나요?
We have more 5 minutes, and then we really want to see your fantastic job on Sanjo.
Sorry about the pressure
No
wire.
problem, not at all. You should not be hurry. This is a very important for patient, and
Okay.
no question about that. Looks like it's not significant.
Yeah.
Okay, now I will pull back.
Okay.
Yeah. Yeah,
Okay, good.
it's really good. Yeah.
Good?
Yep.
Good.
Okay.
Okay, good.
If
Excellent.
you have
excellent.
happy about the result,
Excellent job.
I would like to finish the case.
Yeah.
As I said, no use of the contrast. Okay?
Exactly. Zero, I said.
We cannot enjoy final result.
But at least we need
True.
within one injection, please.
No, we
Please,
need
one
at least.
No,
Just
if,
one
if
for
you
us.
want it,
If
please pay me.
any fellow is here, we need at least 2 projections.
Hey,
so that
hey.
is for very experienced operators.
What would be any additional information that you get at this point from an angiogram? Please, I challenge you.
Satisfaction.
Show to the patient.
We can no. We can ask the audience. Do you need injection? Raise your hands.
No. This
Okay.
is you see.
90%
we
needed.
should
What
no,
is the
come on. We
information
should not
that you are
ask.
getting?
We should not
What-
ask
what
questions
is-
like this one.
what is
Actually,
the
you can't to
information?
see what there could be a lot of many things. First of all, there could be complications. We should. This
Which
is
one?
no.
Which
Then
one?
no. We don't know exactly. It could be also in with wire in distal part and
Okay.
everywhere. There could be also wire. I mean, this is a. If you speak theoretically, it's one thing. Actually, you can't do this because, you know, there is so many also young fellows. You should perforate with wire. This is mandatory. This is mandatory, at least so far. It's mandatory to do angio, and at least in 2 projections without wire.
I agree on distal perforation or distal dissection.
No.
Wire,
I understood what
please, Mi Young, please.
Okay.
Try
Actually,
to finish
please,
this debate
okay.
with just one single injection.
Okay, I will do that.
Okay.
주말 앞으로.
Engage the catheter.
And then remove wire and engage catheter.
Almost be there.
Okay, start.
Oh, fantastic.
Actually, you does not count this contrast.
Actually, you was right.
It
For
was
results,
done
the
inside the
angio
lower
was not
contrast
necessary.
technique.
But at least they convinced us.
Almost a zero
I'm happy that
contrast.
we agree in the end.
No, very good. Thank
Okay,
you.
thank you very much. Thank you very much. Okay.
So, and for after so-called discussions, I'm really asked to CJ Park for lecture and impact of complete vascularization for multivessel PCI.
Thank you, Chairman. Okay, I'm going to talk about the impact of comparative vascularization for multivessel disease. And PCA versus bypass surgery for multivessel disease, actually, so we have very limited data, a very 2D randomized study, freedom study, syntax study, and combined patient-level meta-analysis. I'd like to show the brief result. Very 2D studies focus on the diabetics, the patient who had a low-risk diabetic patient, and the PCR versus medical treatment concern, actually not statistical difference in terms of MACE, death, MI, stroke. However, the patient group who had a high-risk diabetic patient, CABG versus medical treatment, the patient who had a multivessel disease, proximal disease, the patient who had a low ejection fraction, the MACE rate is clearly better in a group of bypass surgeries compared with the medical treatment. You know that the freedom study mainly focused on the diabetics and multivessel disease. Look at the baseline characteristics. Mean age is 63. Diabetic well-balanced between the clinical characteristics, and Euroscore is 2.7, syntax score 26 is quite intermediate, and 3 vessel disease 82-85%. The meaning is far advanced coronary artery disease, number of lesion 5.7, number of stented lesion graft vessel, or graft vessel 3.5 at 2.9 is well balanced between the two. Clearly demonstrate that SMS stroke at 5 years, surgery is better than the PCI with the drug-eluting stent. If you look at the syntax 3 vessel disease subset study, clearly demonstrate surgery is better. So absolute number of MACE rate is quite high, 38% in PCI, 24.2% in surgery. So we have some consensus. Drug-eluting stent versus bypass surgery for multivessel disease 2017. CABG was superior to PCI with the drug-eluting stent in patients with diabetes and advanced coronary artery disease, predominantly 3 vessel disease. However, if you look at the study used, the drug-eluting stent, mainly they used the first generation drug-eluting stent. Very 2D study, DS 35% only, the remaining cases 56%. They used the bare metal stent, freedom study, Cypher, and Texas, and syntax study, they use 100% Texas stent. So we have some question about can you make a better clinical outcome, new drug-eluting stent, and so we did best trials, a patient with a multivessel, mainly 3 vessel disease, random with a PCI with a Giants B, second generation of drug-eluting stent and bypass surgeries. We're going to see TSMI, repeat revascularization, and clinical endpoint. Baseline characteristics is quite well balanced. mean age is 64, 65, diabetic 40%, and if you look at the procedural characteristics, total stent number is 3.4, total number of graft is 3.1, is quite well balanced. Total stent length is 85 millimeters, and complete revascularization rate is 51% in a PCI group. However, bypass surgery group, complete revascularization is 72%. So if you look at the best 5 years outcome, primary endpoint test, MI, TBR, bypass surgery is 11.7%, and PCI with the Giants, second generation drug-eluting stent, 17%, statistically significant different. Exactly same trend with the syntax studies. We did not make any, better outcomes compared to the syntax. Primary endpoint of syntax, death, MI, stroke, or any repeated revascularization. Same primary endpoint with a syntax study, 3 vessel subset, 24 surgery, 37.5% in the PCI with the Texas. Absolute number of adverse outcome is decreased, 14.6% in surgery, 21.7% in PCI with the Giants. However, still clear statistical significant trend is the surgery is better than the drug-eluting stent with the PCI. We gathered the patient level meta-analysis and syntax, best and pre-combat, including 3,280 patients. Multi-vessel disease subset test, MI stroke is clearly better outcomes in group with the surgery, 12.4%, 18.6% in the PCI. So secondary clinical outcome, test MI stroke in best randomized study, actually not statistical difference between the two. If you look at the mortality, any cause mortality, look at this, there are some better outcomes in a group with the bypass surgery rather than the PCI. Myocardial infarction, 2.8%, 5.5% in PCI is almost 2 times higher. And so we did random analysis, it's 30 days, clearly higher periprocedural myocardial infarction in bypass surgery group. However, 5 years follow-up period, 0.8%, myocardial infarction in bypass surgery, 4.2%, almost 4 times higher, statistically significantly higher in a group of the PCI with the Giant. Random analysis of deaths, not statistically different. However, look at this, 5 years follow-up period, there are strong trend is better outcomes in a group of the surgery, 4.6% in surgery, 7% in PCI. So combine the deaths and MI, and look at this, 5 years follow-up data, statistically 0.05, not statistically significant, however, significant lower death NMI in 5.5% in bypass surgery, 9.6% in PCI. Stroke, absolutely same. Any revascularization is clearly higher in a group of the PCI. And if you look at the separate with the target vessel, target lesion revascularization, and new lesion revascularization, target lesion revascularization actually not statistical difference between the two. However, new lesion revascularization is clearly higher, almost 2.5 times higher than PCI with the Giants. Almost the same messages from New York State Registry. Giants, propensity match with the Giants, 9,000 cases, deaths, actually not difference between the two. Myocardial infarction is clearly higher in a group of the PCI. Stroke higher is a bypass surgery. Revascularization is higher is PCI. So we've learned from this registry data and the randomized study, CABG is still better for multivessel disease, even after new drug-eluting stents we use the Giants. So we have some question about complete versus incomplete revascularization for the PCI group, and so we have some subgroup analysis from the New York registry data. Complete revascularization, if you look at this, there's hard endpoint, absolutely no difference between the two. Even frequency of myocardial infarction is no difference at all. Stroke is still higher. With the surgery, revascularization is a higher PCI. Incomplete revascularization is a little bit different. So not statistical difference, however, a little bit higher death rate. Myocardial infarction is clearly statistically higher. Stroke higher in surgery, revascularization higher is a PCI. Same ways, from the best trials, we separate the complete versus incomplete revascularization. That's at 5 years, not statistical difference, a higher trend. Myocardial infarction, absolutely no difference. However, incomplete revascularization group here, frequency of myocardial infarction is almost 3 times higher compared to the bypass surgery. So we analyzed again from the combined patient levels meta-analysis, complete versus incomplete. In the PCI group, clearly demonstrate incomplete revascularization had a higher cumulative MACE rate. Bypass surgery is okay. If you look at the any cause death, MI, stroke, look at this, complete revascularization is quite the same, comparable with the bypass surgery. However, incomplete revascularization had a worse outcome compared to complete revascularization. It's the same finding, death, MI, stroke. We have our independent AMC multivessel registries. We analyze the same way, complete versus incomplete. Look at this, incomplete revascularization had tendency is a worst outcome. Absolutely, the frequency of myocardial infarction is higher with the incomplete revascularization. So what we learned from the current data, complete revascularization is very important practical issues. So if you look at our guidelines, 2014, still we used the syntax score, so low docile is good, 1B class. However, in intermediate docile, high syntax scores we cannot do, actually is according to the guideline concern. However, syntax score is not too much really matters in our real practice concern. This really showed this slide. The angiographically, visually cerebral disease, 115. Among them, if you got some FFR concept, functionally significant cerebral disease only 14%. Very small number of significant. So I think it's a totally different concept, different world. Actually, we need more, solid data from of M3 study and the other, future randomized studies. Reason, so I would like to practical guidelines in our current practice for multivessel disease. Reason is a favorable anatomy for PCI. Complete revascularization should be considered. If the reason is unfavorable anatomy for angioplasty, actually send the patient to the surgery. So multivessel PCI versus CABS concern, we need absolutely new data about the future role of PCI bypass surgery in functionally significant multivessel disease subset. Thank you for your attention.
And now it's my privilege to ask Jim Margolis for the really new topic about laser lithotripsy.
Thank you very much. The topic I'm going to talk about has been discussed in hallways, but not published except in one article going back now 6 or 7 years. There's a lot of confusion about how to do this procedure, how it works, and there was a live case at TCT last year that didn't come out very well. So I thought I'd try to clear the air a little bit. If you take routine Ivostat, about 15% of stents are underdeployed. It's especially a problem with inexperienced operators who invariably choose undersized balloons and stents because they think they're safer. We know that underdeployed stents that are too small, give us continuing symptoms, in-stent restenosis, and early and late stent thrombosis. With in-stent restenosis, we have a number of ways of treating it, and we do it almost every day. But with disease that's outside the stent, It can only be addressed with the procedure I'm talking about or bypass surgery. The technique we're going to describe has purposely creates and accentuates what is considered an undesirable side effect during laser angioplasty. This is analogous to CTO techniques where one intentionally goes subintimal, or the technique for fighting forest fires of starting a fire from the direction to which the original fire is advancing, in order that when the two fires meet, there will be nothing left to burn. The purpose of this procedure is to break up material outside the stent, both calcium and fibrous material, using a bad side effect of excimer laser ablation, which is an acoustic effect. The acoustic effect is generally considered undesirable and can lead, and does frequently lead, to dissection. When we do normal laser angioplasty, we do everything we can to minimize the acoustic effect by the injection of saline and avoid the injection of contrast, which magnifies the acoustic effect. We need sound. I'm sorry. Do we have sound? Bzzz. Bzzz. So this is to demonstrate the cavitation that you get when you first use. In the first picture we had saline in the syringe, and in this picture we have contrast. And the sound is quite different. You see the formation of bubbles in a syringe, and these bubbles you can also see inside an artery if you laser in using contrast. The technique we use in Miami, which I believe is the right technique, we use undersized laser catheter at maximum power. That's a 0.9 millimeter catheter at 80 hertz and 80 fluents. We inject contrast during lasing, which is absolutely contraindicated for a normal excimer laser procedure. We repeat this 2, 3, or more times, but we don't move the catheter inside the artery while we're lasing. We confine the lasing to the inside the stent, being very careful not to go outside the stent. We follow with a generously sized high-pressure balloon until it's fully expanded. If the balloon will not fully inflate or expand, then we repeat the lasing. This is a woman I did 7 years ago with this procedure. There's another video that needs sound, okay? Not this one, it'll be later in the case, in the presentation. So this is a lady who was 3 times in 1 year back with in-stent restenosis because of an under-deployed stent. We had follow-up angiography 3 years later from another lab, but this is as good as it gets for a lesion that couldn't be dilated in a conventional manner. This technique also works for very late extrinsic compression of older stents. Patients who have stents, especially in the proximal portion of the circumflex artery, who have stents in for 5, 10, or 15 years, develop calcification around the area, and that can compress the older stent. This is a 61-year-old man who had a bare metal stent in 2000, brachytherapy in 2003, and was free of all symptoms until 2009, when he came back with both in-stent and extra-stent restenosis. You can see, just distal to the lesion, you can see a large hunk of calcium by IVUS. It was very obvious that that was a problem. There was 80% stenosis of the LCX within the stent and severe fibrosis outside the stent. We tried cutting balloon, which even at 16 bar didn't really do anything to the lesion. We then used the excimer laser in the way I described, and following excimer laser with a high pressure balloon, it was possible to fully expand the balloon. I'm having trouble, okay. So we now have a fully expanded balloon. We went ahead and put in another stent, which was a Xience stent of 4.0. And the final result looks like that. This patient is also out 7 years. He had a 7 square millimeter MLA, and he has a normal stress test. He's not had any angina. He's at full and unlimited activity. This technique looks easy to do, and at least in the case of the 2 cases I showed you, very successful. Obviously, I picked the best cases, but it's very important in doing this technique not to move the laser during lasing. You're not trying to remove material from inside the stent, but rather you're trying to create chaos outside the stent. Even though the laser catheter sits in the middle of these stents, the accentuated acoustic effect extends the entire length of the stent and beyond. Think about an earthquake. Do not lase outside, proximal or distal to the stent. Here's what happens when you don't obey those rules. Could we have sound, please? Can I stop this long enough to get sound? This is Paul Tierstein doing a case at TCT last year, and we all know Paul's about as good as they come in doing PCI. Do we have some? I need sound for this picture. Thank you. Are there any questions while we wait for this?
Yes, I have a question, Jim.
Go ahead.
Do you have any experience with surgical stitches? They can pinch the circ. Can you do it inside the stents? They are just squeezed by...
Oh, with a surgical suture?
Yes, sir.
The answer is I have no experience. I think probably they could. You know, that was the first experiment that Grinsig did on dogs, was to surgically suture the artery and break it with a balloon.
Okay.
When do you stop?
When do I stop?
Yeah, when you put the laser, you make cows, and then to open it. You stop that. How do you are sure that you are finished the job and you're going for the balloon?
Well, certainly I use IVUS controls, but the key is being able to fully inflate the balloon inside the artery. If I don't have a full inflation of the balloon, then I'm... it's called laser lithotripsy. So this is... All right, I'll try to narrate this. I was on the panel moderating this case and explaining what to do. But the problem is that the usual excimer laser technique is to advance the laser 1 millimeter a second during lasing. And that's not the technique for this procedure. You need to leave the catheter right in the middle of the stent and not move it when you're lasing. And the last thing you want to do is to lase outside the stent. So you'll see is at the end this catheter goes distal to the stent. John Hodson was moderator at the time, and he mentioned that was not a good thing to do. So they take a picture afterwards, and now there's no flow down the LAD. And we'll go to the next slide. So in summary, laser lithotripsy is a technique usually using an undesirable side effect of excimer laser angioplasty to resolve 2 previously unmet needs. When used properly, it's a powerful technique that can work wonders. When abused, it takes controlled chaos and becomes chaos. Thank you very much.
Okay, thank you very much, Jim. It was great, and thanks for all panelists. Thanks for audience. I guess we've really seen a very nice operation and very nice procedure with very good result. And And thanks for comments. And sorry, Evelyn, and I guess you are right, and you will be right always. Evelyn's for you, of course.
No.
Okay, thank you so much.